Now I have the pleasure to introduce Professor Badr Almustafa from KSA. He will give a very important lecture about hypertension in elderly, multi-facets assessment.
Assalamu alaikum wa rahmatullah. I hope my voice is clear for you.
Alaikum assalam wa rahmatullahi wa barakatuh, Professor Badr.
It is my pleasure to be with you. Thanks for the organizing committee. Thanks for our old colleagues in Egypt. And I hope that I'll be joining you for the coming 15 minutes, covering the management of hypertension in elderly, where we are having multiple of challenges faced. And as well, the challenges is not only for the diagnosis or fixing the blood pressure level, but even for the variability of the blood pressure. And we will cover in short how to assess these patients and if there is any benefit of a treatment or not, and to put all that in real practice. In Egypt, my very short review, it is estimated that by 2050, almost the population will reach about 160 million, and with a life expectancy raising from 69 currently to 74 to 80 in ladies. And the elderly may increase up to 22 million of this population, which is around 14%. This 22 million, just recall that more than 50 to 70% of them may have high blood pressure, as we all know from the current statistics. Egypt and the current situations is not that doing well in the diagnosis, neither the treatment or the control of the blood pressure, and this will be more special in the elderly populations where their income as well the reach to the healthcare will be limited in comparison with their counterparts. Elderly by definition are confined for those aging 65, though this is chronological definition of elderly, and the elderly is confined for those who are above age of 80. And I've just stated that most of the elderly will be having high blood pressure in their age groups. And it is usually isolated systolic hypertension. This is not true isolated because the diastolic blood pressure is usually out of touch because of the arterial stiffness that is very popular in this age group, and our machines will fail to detect the this blood pressure level. Elderly are used to have increased comorbidities. Almost most of 20% of the elderly have more than 5 chronic diseases. It might be cardiovascular, renal, but diabetes, but as well musculoskeletal, and in addition, for males, might be prostatic issues. Cancer is another comorbidity, and having increased cardiometabolic risk factors, these per se is increasing the chance for every person to get cancer. We are having more white coat effects. This makes the diagnosis and the treatment of blood pressure so difficult. The blood pressure variability is very high, as just stated, especially after the age of 60, we are having increasing in the systolic while decreasing in the recording of diastolic blood pressure. And from daytime to nighttime, and as well from positional and other factors like mood changes, all these makes blood pressure so vulnerable to change. This age group is as well known to have poor adherence, especially if they are experiencing some change in the adverse events of the medications that they are taking, which makes their tolerance for the change of dosages and as well adding new medications so hard. this urge us to have follow our patients more closely. And as we all know, there are a lot of changes in the pharmacokinetics and as well the dynamics of the medications that we are giving in this age group due to change in the water volume, change in the fat percentage, and as well changes in the renal and liver functions and masses. There is a chance for increased chance for postural hypertension for all that changes. The polypharmacy is another challenge that we need to deal with it very carefully. And this, I would say, without the help of a good team of whether it is being a nurse practitioner or a clinical pharmacist, this will be very hard to achieve unless you afford a good time for the patient and for the caregiver as well. Having said all that, the assessment started with a good, careful blood pressure measurement, taking into consideration what I've just mentioned in the prior few minutes. And for that reason, we have to have more carefully measure the blood pressure. And would be, I would say, out of office blood pressure measurement has to be relied on. Even the ambulatory blood pressure is not easy really to interpret. We may need to have multiple ambulatory blood pressure measurement readings to reach a conclusion for each patient due to many factors that make the ambulatory blood pressure not really dependable. We need to stick in the assessment not only for the blood pressure, but as well how urgent is the case. We have to have good stratification of the cardiovascular risk of the patient. And as just mentioned by Professor Manshi just a few minutes ago, that the decision to have the patients at elderly to decide is not only the blood pressure level, but in addition to that, the cardiovascular risk stratification and whether the patient is fit enough. And for this reason, we are assessing the patient, his risk to have falls. He can depend on himself and how far he is doing in the mental part of the assessment. Many comorbidities are over there, which has to be assessed as well, because there is a big chance for interchange of their presentations and as well, which may mimic some adverse events of the medications or target organ damages. And an example of that is lower limb edema. And in addition to that, we might have some contraindication for our interventions. We have to have a good relationships, not only with the patient, but as well with the caregiver in addition. And we have to assess how far the patient and the caregiver may comply with our approach and change of the plan of medications. We need to listen to our patients. We need to listen to know what are in their minds. It might be that the urinations is a problem for them, and giving the patients some more diuretics or some medications that make diuresis more may make them really worse in their improving their quality of life. Quality of life must be considered number one in these age groups. For these reasons, many models have been put to assess, and we have to assess all these, which I am presenting in this slide. And the lower, you can say that gait has to be assessed and the cognitive functions carefully. Sleep has to be put in mind for these patients. We need to assess his mood by using whatever the geriatric, for example, depression scale or BHQ-9 depression scales. This is cardiovascular risk estimations, which we use it as well. And the other part, we have to assess the social issues, whether the patient is getting lonely or not. I've just been in a few studies in Egypt that's showing that lonely elderly is increasing in comparison 2025 data with data which was just 10 to 15 years ago. This means that we are having decreased chance to have a good preparation for and plan of management. The help will be less, change of lifestyle will be less, choose of the good food as well will be less. This is the clinical frailty scale, which we may use it to decide whether our patient is fit enough to go for independent, I would say, plan of management, or no, the patient is so severely frail that we need a caregiver to be with. Now, whether the patient will get some benefit of a treatment or not. Yes, older studies have shown to be that, and even newer and recent reviews have shown that there are some benefits in decreasing the chance for morbidity and to an extent mortality. However, this might not be very true in some of these trials carried over. That makes really the decision to have it very crude delivered to our patients has to be judged upon the frailty from one side, the blood pressure and cardiovascular risk from the other side, and thirdly, the comorbidities. And it has shown it's better that reaching, I would say, initializing blood pressure level at 160 or less. It has been shown more, I would say, confidently that starting at level of more than 160 is the worth for those who are newly diagnosed to be hypertensive. This means that we need to be very careful in starting antihypertensive medications for newly diagnosed hypertensive patients at a level below 160. This has to be judged in view of the other issues that I just have mentioned priorly. And this, I would say, slide, you would say the multiple guidelines have different recommendations. These, for example, 3 guidelines in below, they may start blood pressure levels, blood pressure antihypertensive medications at blood pressure level of 130. But in some other guidelines, for example, the one in the left, or the second on the left, or the one in the middle, they would differentiate whether our patients are above 65 or above 80. And for those, especially above 80, we have to be very careful to go starting blood pressure lowering if the blood pressure level is below 160. I have just made reviews, and this is more detailed in our regional as well international. And you can see on the right here that most of the guidelines, they would recommend to go for safely, especially for those above 80 to start if the blood pressure above 60 and not to reach much below 150, 90, unless the patient is tolerating the lower blood pressure level. And this cannot be done safely without continuous, regular, multiple visits for the patients and having home blood pressure readings available, and as well to assess the symptoms of the patients. To make it in short, this is, I would say, conclude the guidelines safer approach. The medications to be used with putting in mind the change in the pharmacodynamics and kinetics that is, I would say, concluded in this slide. We have to go very slow in our approach and to be very careful if I'm going to use diuretics. However, it might be preferable due to the isolated systolic blood pressure level that my guide seems, or to go to the very low dose of CCBs, especially amlodipine. If we go it very slow, I would say low dose, this will give us a chance to not only to, I would test the response, but as well the adverse events that might the patient experience. And I would titrate thereafter. The other medications and the classes might be used if there is compelling indication, if we use. However, we used to refrain of using alpha blockers in elderly, though we know that our patients are using, for example, antiprostatic medication, which might as well add to their blood pressure lowering effects. We have to carefully assess the renal functions now and then for our patients before and as well after every change, not only introducing the new medication, but as well in every change in there. In some patients, they may not even tolerate the change of the trademarks. They may not, even though the generic is the same. So we have to put that in mind. To come to conclusion, we have to assess the phrenitis care of our patients. And once he's having preserved function, we might deal with him as the other adults. But once it is not, we need to be very careful, and we have to keep the blood pressure just around below 150 and to reduce it very carefully by time scale. And we have to assess and to consider discontinuation or decreasing the doses if the patient, if our medication is not effective enough, or we are having accumulating side effects, or there are some other issues that the patient is not tolerating. And this cannot be done without having regular monitoring of our patients. Our patients may like to go to Hajj or Umrah or to travel. This has to be put in mind, especially that they are feeling that these are maybe their last few years of life. This has to be respected, and we have to afford to them better assessment before travel and after travel and during travel if possible. To conclude, evidence supports that there are some cardio and as well neurovascular benefits of treating hypertension, and these issues has to be put in mind with avoiding the harm as much as possible. The choice of antihypertensive medication must consider all these indications. If there is any concomitant medications in use, the renal function, multiple readings of the renal function, and the likelihood of developing adverse events. We need to employ shared decisions, not only with the patient, but as well with the caregiver, and to start slow and to go very slowly with multiple visits to our medications. This would conclude as well the blood pressure levels to go for, and we have to refrain of going below 130, and especially for those above 80, or for those below 80 to refrain to go below 120/70 as possible. How to tune it to reach that one? Lifestyle might do the job. Our patients, elderly patients, are showing more salt sensitivity, so we may make use of that. Some exercise, even isometric exercise, even for those bedridden, isometric exercise might help them to tune out the blood pressure levels. For those who are having currently blood pressure levels below 120/70 may, I would say, be a challenge. However, we need to measure the blood pressure frequently before deciding any change. Thank you.
Thank you. Thank you, Professor Badr, for this very comprehensive coverage to the very hot topic, which is hypertension in elderly. Unfortunately, there is no time, for the sake of time, no time for questions. And hoping to be with us next year physically, inshallah. Thank you very much.
Inshallah, as used to be.
Yeah, thank you.